Good evening, doctors. On behalf of myself, Shubhojit Mukherjee, SBU head from Harmonica Acumentis Healthcare Limited, would like to thank FIGO and REI committee for bringing this third module in the 6 online module series of continuing medical education program masterclass on endometriosis. A quick word about Acumentis, doctor. Acums is India's largest manufacturing setup with 12% of all the pharmaceutical tablets, capsules, injections which are sold in India come from our stable. Acumentis is the formulation marketing setup under Acums, and we currently span the TA of gynecology, pediatrics, ortho, dermatology, ENT, and of course cardiology and diabetology. Quite a few brands of ours were the first of their kind, and we take great pride in successful launching innovative formulation. Next slide, please. Now, this is our motto. The vision is to become a global healthcare company, empowering each and every patient on earth with novel healthcare solutions to fight the discomforts. Acumentis has, as I have said, 9 strategic business units, and our division Harmonica serves is the women's healthcare serving through gynae, obstetrics, and IVF. Next slide, please. These are our 4 therapy areas. We deal in medical management of uterine fibroids, medical management of endometriosis, medical management in PCOS, and IVF therapy. We are shortly coming in management of postpartum hemorrhage. So great to have doctors from India and abroad with us in the third module. And let me take the pleasure, next slide, in welcoming Dr. Jaideep Malhotra, without whose support this program would not have been possible. To introduce Dr. Jaideep Malhotra, it's a privilege for me. She is the Director, ART Rainbow IVF, President SAFOMS. She is the past President Foxy, Aspire, ISAR, IMS and ISPAC, President of Indian Society of Prenatal Diagnosis and Therapy. Dr. Jaideep is Vice President, Indian Society of Aesthetic and Regenerative Gynecology, Regional Director, South Asia, Jan Dolan School of USG. Dr. Jaideep is the Professor, Dubrovnik International University, Croatia, Editor-in-Chief, SAFOG, SAFOMS journals and many books. She is a member of FIGO Committee of Reproductive Endocrinology and Infertility and FIGO Working Group on RDEH. Dr. Jaideep is the recipient of Honorary FRCOG and FRCPI. She has the Lifetime Achievement Award from ISSRF and Amar Jala Gaurav Samman Award. She holds a place in India Book of Records and World's Records on India's awards Swayam Siddha. She has been awarded by the Honorary Governor of UP Sri Ram Nayak for the Indumati Javeri Prize. So over to Dr. Jaideep.
Thank you, Shubhajit. Thank you so much. And a very good evening and a good morning to everyone all around the world who is logged on to this wonderful masterclass from FIGO REI committee. It's indeed a pleasure because we have seen over the last few lectures that the response has been tremendous from India and also from abroad and the neighboring countries. And I like to put on record my sincere thanks for Acumentis for organizing this, and to our wonderful, wonderful speakers from all over the world who have deliberated on this topic. Today we have a very, very interesting and the most intricate and difficult part of endometriosis, which is going to be deliberated by one of the key and the most fantastic speakers on the topic concerned. And it is my proud privilege right now to introduce my wonderful, wonderful friend and who's also the chair of the FIGO REI committee, Yvonne Diaz Yamal. Yvonne is the chairperson of FIGO REI Committee for Reproductive Medicine, Endocrinology and Infertility. She is from Colombia. She has been there with us for all these masterclasses. Yvonne, tell us something about the FIGO initiatives and also what REI committee is doing, for all these years and what is in store.
Thank you, Yaiti. Thank you, and thank you very much for your attention here in this important event, Masterclass of Endometriosis, for the Federation International of Obstetrics and Gynecology, FIGO, and especially for our committee in Reproductive Medicine, Endocrinology, and Infertility. Be here is very important for the education, not only for the professionals in gynecology, and the other way is for the woman around the world. So I think it is very important this case for endometriosis can to affect infertility and reproductive medicine. Thank you, and I kindly thank you invitation for being here. Thank you very much.
Yeah, thank you, Yvonne. All this has been possible with your kind support, and you have been phenomenal. Actually, getting up early in the morning. I remember the last one which we had. It was like in the middle of the night for you, and you were there. It's really been impressive support, for this masterclass. Thank you very much. And for everyone, Yvonne is the course coordinator for this masterclass, and we're going to have a certificate after the completion of the 6 lectures, and there will be a small test which all of you who are attending are supposed to appear. It gives me a very proud privilege now to introduce our 2 chairs for this session. We have Dr. Pratap Kumar. I'm sure everyone in India knows him. Pratap is professor and head of the Department for Reproductive Medicine and Surgery at Kasturba Medical College, Manipal. Manipal is known for its all academics, and you will soon see when Pratap starts deliberating on the subject. Pratap, thank you very much for being there. And our other chair is Dr. Naren Malhotra, who is the Managing Director of Global Rainbow Healthcare. Naren also has held many posts for various organizations like FOXY, IFUMB, ISAR, ISPAT, and is also a professor at the Dubrovnik University, and is very keen, has keen interest in ultrasound, endoscopy, obstetrics, and you name it, and it's all there. So welcome to both of you for this particular wonderful session on the diagnostic dilemmas and management of endometriosis. It now brings me to introduce our speaker. Our speaker for today is none other than David Adamson. He's a very close friend of ours. He has been the past chair of the REI committee for FIGO. David is a board certified reproductive endocrinologist and surgeon at Palo Alto and San Jose, California. David has received MD degree and residency training at the University of Toronto, Canada, and his reproductive endocrinology, infertility and surgery fellowship training at Stanford University, School of Medicine in Stanford, California. He is a fellow of Royal College of Surgeons of Canada, the American College of Obstetricians and Gynecologists, and American College of Surgeons. He has held many posts. I mean, it's phenomenal, David. Even I did not know. You have been the past president of American Society of Reproductive Medicine, the world's largest and the oldest medicine professional society. And I want to read your CV because I want people to know you better, because we have known you for your talks, but this is really phenomenal. You have also been the past president of AAGL, the Society of Assisted Reproductive Technology, the Pacific Coast Reproductive Society, the Society of Reproductive Surgeons, San Francisco Gynecological Society, Bay Area Reproductive Endocrinology Society. You also have been the board member of the International Federation of Fertility Societies, Secretary Treasurer of International Committee Monitoring of ART, that's ICMAT as we know it, and the president of the World Endometriosis Research Foundation, Now that's really phenomenal, and I don't think we could have had a more apt speaker than you. You have actually published more than 125 peer-reviewed scientific articles, book chapters, and even edited 3 books, and have presented lectures extensively on reproductive medicine, surgery, endometriosis, ART, and infertility. David has he has listed in the Who's Who in America since 1990 and is recognized by Good Housekeeping magazine and as the one of the best 400 physicians for women in America. In 2006, he received Outstanding Achievement in Medicine Award from Santa Clara County Medical Society, where he practices, and a Certificate of Special Congressional Recognition for Outstanding and Invaluable Service to the community. For a lot of you who don't know, I'm sure all of you have heard about the fertility toolbox, and also you have heard about the classification for endometriosis, and David has a lot to contribute there. So the stage is all yours, David. We are really keenly and eagerly wanting to listen to your dilemmas in diagnosis and management of endometriosis.
So welcome, Professor David Addison, and we would like to request you to start your talk on dilemmas in diagnosis and management of endometriosis.
It's really a pleasure to be here with you today to talk about dilemmas in diagnosis and management of endometriosis. I would like to thank FIGO and Dr. Jaideep Malhotra, as well as all the members of the organizing group for inviting me to this very prestigious lecture. These are my disclosures. I do not believe they will have any impact on this presentation, but it's important for you to know what they are. And I'm prepared to answer any questions about them at any time. So let's talk about dilemmas in diagnosis and management of endometriosis. Starting with diagnosis, we know that endometriosis is a very complex and chronic disease that affects about 200 million women globally. The symptoms of endometriosis are very variable in nature and severity. They can include pain during periods or sexual intercourse, with bowel movements and/or with urination. In addition, many patients get chronic pelvic pain as a result of central sensitization of the neurologic system. This can occur at any time throughout the life course of endometriosis, can occur with or without lesions, and with or without treatment. In addition, other systems such as abdominal bloating, nausea, and fatigue in the gastrointestinal system can occur. Sometimes depression or anxiety, which may be a direct result of the endometriosis or associated with it, also occur. We also know that infertility can be caused by endometriosis about 20% of the time, or at least associated very strongly with endometriosis. Indeed, these symptoms, even though they're felt to be estrogen dependent, sometimes persist after menopause in 2 or 3% of women. Furthermore, some women may have endometriosis and be entirely asymptomatic. So these very variable symptoms create a great deal of difficulty in making a diagnosis. As a result, there is commonly delayed diagnosis of 7, 8, or 9 years because of these variable symptoms, and the symptoms can change over time. As noted, they're often associated with other conditions in the genitourinary system, or the gastrointestinal system, or the musculoskeletal system, which make it very difficult to make a diagnosis. And finally, because of the fact this is about sexual and reproductive health, many women, and certainly many people in society, are not particularly aware of endometriosis and these myriad of symptoms. Confirmation of a diagnosis of endometriosis can be difficult, especially because there's little correlation between symptoms and the extent of disease. Endometriosis can present also in multiple ways, as superficial pelvic peritoneum, as endometriomas, as deep endometriosis in the rectovaginal septum or the bowel or the bladder, and rarely elsewhere in the body. Physical examination can be helpful if there's an experienced examiner. This might include the finding of rectovaginal masses or ovarian enlargement. The rectovaginal masses often can be reasonably pathognomonic of endometriosis. Imaging has been very helpful in making the diagnosis, especially ultrasound, because it's affordable in most parts of the world and available in the gynecologist's office. Additional testing with MRI can be quite expensive. CT is of very limited utility. We also know that diagnosis can be made by surgery. And indeed, for many years, diagnostic laparoscopy was a prerequisite for diagnosis. This is no longer true. But laparoscopy can be helpful. Very rarely is laparotomy needed in order to diagnose disease and, of course, treat the disease. It's important to get a pathologic specimen if at all possible. Endometriosis is not always found in the pathologic specimen, but it's important to get it to try to confirm the disease. And there's been variable opinion about whether a pathology specimen is absolutely necessary for the diagnosis or not. Most people feel it is not absolutely necessary, but is definitely preferred. In addition, of course, in the last decade or so, there's been a great increase in non-invasive biomarkers, which would help us greatly in making a diagnosis of endometriosis. However, it is not easy to find a biomarker that will be helpful. Many of the biomarkers are focused first around the endometrium and the endometrium-like tissue that occurs with endometriosis. But there are many different processes within the body and many factors that affect the endometrium and potential endometriosis lesions. This results in many potential biomarkers, most of which have been studied at one time or other. But this is what a potential figure of biomarkers would look like. And as we can see, this is an exceptionally complex picture for one to try to unravel with a biomarker. As long as over 10 years ago, systematic reviews of peripheral biomarkers were being carried out, and they confirmed at that time that there were no validated biomarkers. And even today, as recently as in the past year, we have new studies showing the potential role of messenger RNAs as biomarkers. However, today, I think it's fair to state there is not yet a biomarker that has passed the biomarker study triangle test, which is that we come up with a hypothesis about why a biomarker might work. And then we do a pilot study if it appears to be helpful. And then a large replication study must be done to show that the biomarker works. But this is not sufficient. Once we think we have a biomarker, it must be studied in a validation study that is prospective and, very importantly, as a carefully defined set of patients for whom the biomarker is being tested. Is the biomarker being tested for amount of disease, for pelvic pain, for infertility, for efficiency or effectiveness of surgery? And these are questions that are commonly not addressed in studies that we see in the literature. So unfortunately, today, we do not yet have a biomarker that can be used clinically in an effective way. But there is a great deal of work going on in this important area, and we certainly hope soon to be able to find a non-invasive biomarker. But this is certainly one of the remaining dilemmas in endometriosis. Now, there are also dilemmas in the management of endometriosis. This occurs because, of course, endometriosis can present with pain or with infertility or both. And in addition, it can present with endometriomas and or deep endometriosis, including in the bowel or in the bladder. Another confusing aspect of endometriosis has been adenomyosis and adenomyomas. Historically, these conditions were thought to be very strongly related, if not similar-like conditions in different anatomic regions of the pelvis. However, there's a great deal of work going on today to study adenomyosis and adenomyomas in more detail to understand what the relationship is and how these diseases may be similar, but also we are pretty certain now are in fact different diseases that are related. In addition to the difficulty with management, it's complicated by therapeutic modalities that are highly variable. First of all, we have medical intervention, medications such as hormones, primarily progestins, and drugs used to lower estrogen levels because endometriosis is an estrogen-dependent disease. Very commonly used are analgesics, of course, but especially these days, we must be very conscious of the risk of addiction with narcotics, and these should be avoided. Other medications have also been used, including anxiolytics and a large array of different types of meds for women with this disease. We must remember, though, with all medications, there are side effects. Some of these may be trivial, but some may be very serious, such as bone loss with agonists, especially if used over a long period of time. Surgery can be helpful, but surgery can either be conservative, that is removing disease and leaving in the tissue to be as functional as possible, or it may be more radical with removing organs such as the ovary or such as the uterus. However, of course, if a woman wants to retain her reproductive capability, then this is not possible. An additional problem with surgery and another real dilemma is that endometriosis surgery can be very, very difficult, both in the diagnosis and in the surgical techniques that are used. And this means that in many, many places of the world, there's not sufficient expertise with surgeons and facilities to provide high-level care for women who have this disease. Complementary medicine for many years did probably not get the attention that it should with endometriosis. Now, especially as there's been more collaboration with the pelvic pain community and the endometriosis community of researchers, there's a greater understanding of the potential value of complementary medicine that can help deal with central sensitization. This is an area now of a lot of research that's going on, but we still don't have a very good understanding of which modalities may be most helpful. These can include physiotherapy, of course, mind-body work, and other approaches to manage chronic pain. Other issues that we have to deal with endometriosis that do create dilemmas are the fact that we think there are many different factors that cause endometriosis. Traditionally, the classical cause has been retrograde menstruation, but also there's a definite evidence for cellular metaplasia, and also stem cells with hematogenous and lymphatic spread that cause endometriosis. We do know that this is an estrogen-dependent disease, and with estrogen, there is growth and inflammation of the endometrium-like tissue that is found outside of the uterine cavity. We definitely also believe through research that altered or impaired immunity affects the extent of endometriosis in many women. So some women may have the same amount of retrograde menstruation, for example, but because of altered immune system, have a much greater anatomic extent of lesions as well as potentially symptoms. We also now believe that there are localized complex hormonal influences around the lesions that we see with endometriosis. Undoubtedly, genetics play a role in this. Multiple whole genome studies and other studies have demonstrated that genes have a role. There is a familial contribution here. And finally, environmental contaminants, potentially and likely, especially those that have estrogen-like effects, do have a role in the development of endometriosis. And finally, a major dilemma, as alluded to earlier, that many countries, especially lower middle income countries, have a lack of awareness of both patients and professionals, both through insufficiency in the education system and the health system, also often through cultural taboos, so that there's not much awareness of endometriosis. And of course, endometriosis diagnosis and treatment can be expensive. And so there can be a lack of training of healthcare professionals, referral facilities, and definitely a lack of multidisciplinary treatment, even in most developed areas of the world today. And finally, the cost of all of these different approaches result in many people not having access to care. So today we're going to look at some of these dilemmas and describe a diagnostic approach for endometriosis, despite the fact there's so much that's not known. And we're going to explain different management approaches for infertility and pain based on evidence in the literature, and then list some of the many major challenges and priorities that require global collaboration and research in order to make progress in this area. So first of all, let's discuss infertility and causes of infertility. We know that often about 10% of infertility is felt to be unexplained, and female-only factors occur about 40% of the time, with oligoovulation, age, diminished ovarian reserve, and hormonal causes of female-only factors. These can also occur with pelvic factors, of course, endometriosis being the one we're discussing primarily today, but other pelvic problems such as adhesions and fibroids, Müllerian abnormalities, etc., can create pelvic problems. Male-only factor occurs about 1/4, 25% of the time, and so it's obviously important to check sperm count, motility, and shape, although we still don't have good tests of sperm function that can be used on a routine basis. And both female and male factors occur about 25% of the time. These can have to do with performance or infection or other issues. And so it's important when infertility is a presenting problem with the patient and endometriosis is being considered, also to note that all factors have to be worked up both in the male and female before a good management approach can be identified. If we look at the diagnosis of infertility and endometriosis from an ovarian point of view, we can get a lot of information with a very few simple questions. Ask about menstrual history, when menarche occurred, and irregularities. Important. Normal is 22 to 35 days, and length of menses 3 to 7 days. Pregnancy history indicates a higher chance of subsequent fertility. Duration of attempting pregnancy is very important. Once individuals have tried more than 3 to 4 years, it's possible, but not very likely, that conventional treatment or observation alone will result in a pregnancy. Other factors need to be considered and ruled out, such as polycystic ovarian syndrome, thyroid disease, high prolactin levels, or androgen levels, and other issues in the patient's health. And finally, of course, difficult to address, but very, very important, are lifestyle factors such as diet, exercise, body mass index or weight, smoking, and alcohol use, and these should be addressed as they can affect fertility. Within the pelvis, as we mentioned, there can be endometriosis, infections, adhesions, and myomas, but a history of operations or pain are also important to note. With respect to endometriosis and a female history for infertility, the most important attribute is simply suspicion. Think of endometriosis as a possible cause. Take the menstrual history, understand pelvic pain. Again, there are no validated screening tools or tests. Often ultrasound can help identify either endometriomas or, in experienced hands, deep endometriosis. Histology can be helpful, as noted. Laparoscopy when appropriate, and we will discuss this later, but just to make the point that laparoscopy is not needed for every single patient who presents with infertility and suspicion of endometriosis. And of course, if the patient has a situation that is beyond the skill of the healthcare provider, it's important to refer that patient to a more experienced person and facility. One of the great problems with endometriosis is this confluence that we commonly have with both infertility and pain. And we know that the prevalence of endometriosis is high in infertile women, both with and without pelvic pain. As reported in ESHRA guidelines, endometriosis prevalence estimates range from 2 to 10%. I would say the usual number is about 8% or so globally in the world, that women who have endometriosis. But in infertile women, up to 50% can have endometriosis. And so a study that was done in Belgium has results shown here. There were a total of 221 patients of people who had infertility, women had infertility, and with laparoscopy, 47% had endometriosis, almost half. When we look at those with the endometriosis and pelvic pain, 54%, again about half, had both endometriosis and pelvic pain, and they had infertility. And then endometriosis without pelvic pain was about 40%. And so we can see why diagnosis and management can be difficult, because a single woman can present with infertility, chronic pelvic pain, including non-menstrual ovulatory dyspareunia, can also have heavy bleeding, and may be coming after prior treatment with a recurrence of disease. And so this is why this condition can be very difficult to manage. Now, just to comment on this aspect of the use of progestogens, because progestogens can be effective treatment for endometriosis pain, the treatment for endometriosis pain, but there are different kinds of progesterones that have different characteristics, different receptor binding characteristics in particular. And just an example of a few progestogens shown here. And one of the important points I wanted to make was that dydrogesterone, in fact, does not block ovulation. This drug is not available everywhere in the world. We do not have it in the United States, but it's a drug that could be considered to be used in women who need to have a progestin, but who also want to continue to be able to try to get pregnant. But of course, the other drugs are widely used and very effectively in women who have pelvic pain and not attempting pregnancy. So let's look first of all at treatment now of infertility and look at outcomes with ovarian suppression. So we're going to look at both infertility and pain, and we're going to look at ovarian suppression and at surgery, and see how each of these work in these different situations, so that we can identify a treatment plan for the woman who comes into our office. And so first of all, we know that with ovarian suppression, study that we did years ago, as well as Cochrane study, show that with ovarian suppression, there is not an increased rate of pregnancy after treatment. We also know that this effect of oral contraceptives, progesterone, other progestins, GnRH agonists are really similar. It doesn't matter which ovarian suppression medication is used, the pregnancy rate is not different. Now, that's not to say that certain women don't do better on one medication or another. Some women will do very well on progestins, others won't. Some will do very well on a GnRH agonist, others won't. So even though statistically they all come out with similar effect, it's clearly the case that different women respond differently. And of course, this should not be surprising to us. So the evidence in the literature is that there's no evidence of a fertility benefit for medical treatment. And ovulation suppression may delay pregnancy, and therefore is not recommended. And so because of the delay in attempted pregnancy in the infertile patient and the cost associated and the side effects of drugs, don't use ovarian suppression in the woman with endometriosis who's attempting pregnancy. Now, if we look at the management of pain, it's different. And so what outcomes do we get? What we know is that non-steroidal anti-inflammatory drugs, other analgesics, combined oral contraceptives, and progestins are usually well tolerated, low cost, and they're easily accessible in most parts of the world. And they can and should be used as first-line empirical medical treatment. In other words, for the woman who has suspected endometriosis, it's not necessary to do a laparoscopy. It is reasonable to give these other medications that are usually fairly inexpensive and can be effective. Now, for some women, of course, these drugs are not sufficient to manage their pain. And so second-line medical treatment with GnRH agonist needs to be given. I always add back with some estrogen and progestin when I use a GnRH agonist in low dose. These protocols are well shown to prevent hot flashes and most importantly, prevent or severely or limit bone loss. Also, the long-acting levonorgestrel intrauterine system or IUD can also be considered. I've had very good success with that in some women who do not respond to first-line medical treatment. Important to note that the combined oral contraceptive is a very effective medical treatment and can be used to minimize endometrioma recurrence. And of course, it's effective in preventing pregnancy in women who have endometriosis and pelvic pain but do not want to get pregnant. Other medications have been used, such as danazol and gestrinone. They can be effective, but because of the side effects primarily, it is not recommended to use these drugs today. Other medications, such as aromatase inhibitors, selective progestin receptor modulators, GnRH antagonists, might be reasonable approaches in some patients, but they're not yet validated to be effective and safe enough that they should be used as a routine, and so more research is required on them. Now, what about looking at the treatment of infertility and endometriosis with surgery? For many years with minimal and mild disease, it was controversial whether surgery was helpful. Many non-randomized trials that showed some benefit, 58 to 45% overall of surgery versus non-surgery for minimal mild endometriosis in the infertile patient. Fecundities, though, were not very different at about 6 to 7% a month. And then the Endocan randomized controlled trial was drawn out of Canada that showed a higher pregnancy rate, 37.5% versus 22.5% in the non-treated laparoscopy group. However, this finding of effectiveness of laparoscopic treatment was soon followed by the Gruppo Italiano randomized controlled trial, which was much smaller and had some slightly different characteristics, but did not show a benefit, about the same results. However, when these two studies were put together in a meta-analysis, it did show that there was a higher odds ratio for pregnancy if a diagnostic laparoscopy was followed by operative laparoscopy when minimal mild endometriosis was found. And it's generally felt there is some improvement when operative laparoscopy is performed. However, it's important to note that the number needed to treat is approximately 12 patients to get one additional pregnancy. And so while laparoscopy diagnostic followed by operative can be helpful. It's not necessarily the best strategy because you have to do a lot of laparoscopies to get one more pregnancy. And of course, we have other options, which we'll discuss here in a minute. The Cochrane review does conclude that laparoscopy may improve pregnancy rates. ESHRA and the Royal College of O&G do recommend ablation and lysis of endometriosis that's minimum mild when it's found. Now, if we consider moderate and severe disease, the situation is somewhat more clear, but not so much based on the evidence. We know that with moderate severe disease, there's severe anatomic distortion, and we know from multiple papers there's a very low background pregnancy rate in the range of 10%, certainly not more than about 15%. And many uncontrolled trials show a benefit of surgery for moderate or severe endometriosis in the infertile patient. We also know that laparoscopy appears to be better than laparotomy with higher pregnancy rates, probably because there's less trauma to the tissue in the pelvis. And so there's a general sense, and the guidelines recommend surgery is indicated for invasive, adhesive, and cystic endometriosis. It's a reasonable approach and can be effective in the appropriate patient. Laparoscopy should be performed as opposed to laparotomy, of course, whenever possible. Now, it's important to know if we go to the operating room and treat someone, what type of expectations we should have for following surgery and how we're going to manage that patient after surgery. And again, we're talking now about the infertile patient. And these data, published almost 30 years ago, show that if we look at all stages of endometriosis after laparoscopy, the fecundity is about 4 to 5% in the first year. These bars show quarters. So the year one has 4 quarters of 3 months each. Year two, the same. And what we can see is that the fecundity stays in the 4% plus range for about 15 months before it drops to half that or so, where it stays for another 2 to 3 years. So these data are very important in informing us about how we do laparoscopy and how we consider laparoscopy, which we'll come back to in a minute. Now, another really important fact about endometriosis is that even though ovarian suppression is not going to improve pregnancy rates, and we know that laparoscopy will improve pregnancy rates in minimal and mild disease, that does not mean that every patient needs to have surgery. And the reason for that is shown on this slide. If we look at cycle fecundity in women with minimal or mild disease, here are some papers that show that with no treatment or intracervical insemination, the fecundity per month is in the 2 to 4% range, let's say around 3%. With IUI, it seems to be somewhat higher, about 5% or so. And with clomiphene, maybe a little higher, about 6 or 7%. These data, which are quite old, but also new data looking at randomized controlled trials of clomiphene and IUI versus clomiphene alone or IUI alone, show that if IUI is going to be done, clomiphene or letrozole should also be used, and if clomiphenes or letrozole are used, IUI should be done. In other words, use ovarian stimulation with clomiphene and the intrauterine insemination together, and the fecundity will be in the 8 to 10% range or so. And this is the best approach And of course, that is significantly higher than the 2 or 3% with no treatment. Gonadotropins or gonadotropins and IUI are shown here. These are not commonly done now because of the high cost and especially the risk of multiple pregnancy. It is almost always better, and there's good literature data to show that rather than gonadotropins and IUI, it's more cost effective to go straight to IVF rather than using gonadotropins IUI. In most situations, there's the occasional anovulatory woman that would be best served by gonadotropins, but this is a small proportion of patients. And finally, of course, we have IVF shown here with a fecundity of 22% on a cycle. For many developed parts of the world, this number seems very low because live birth rates can be 30, 40, or even 50% per cycle in selected patients. But as a participant and chair of ICMART that publishes the global IVF results, I can assure you that 22% is approximately the global live birth rate per cycle start or per retrieval, somewhere in the range of 20% or a bit more. So these numbers can be very informative when we're performing treatment. Remember that after diagnostic laparoscopy, the fecundity was in the 4 to 5% range, which is a good number, but it is not as high as clomiphene and IUI in both unexplained infertility, which may or may not be associated with endometriosis some of the time, or in endometriosis-associated infertility. This means that controlled ovarian stimulation and intrauterine insemination is appropriate treatment in a patient with other normal factors and suspected minimal or mild endometriosis. So if that's the case, if in that case we should do ovarian stimulation IUI, when do we do laparoscopy? Well, there are patients who should have laparoscopy. Mostly these are women who are younger, probably age 37 or so. They have short duration of infertility. As noted, it should be under 3 or 4 years because over this duration of time, pregnancy rates are low with surgery or any other non-IVF treatment. They should have reasonably normal male factor, normal or treatable uterus, normal ovulation, easily treatable ovulation disorder, and limited prior treatment. They should be an appropriate candidate for laparoscopy with respect to weight and other health factors. If we think that the patient has treatable disease in the hands of the surgeon, then it's reasonable to do the surgery. And it's important, though, based on the earlier data we showed, that if you're going to do laparoscopy, both the doctor and the patient want to be able to commit to 9 to 15 months of trying prior to moving on to other treatments such as IVF. The 9 to 15 months, though, can include ovarian stimulation and IUI. Now, what about treatment of infertility and pain? Well, there are different surgical techniques for endometriosis. And what we know is that laparoscopic surgical removal is probably the most effective first-line treatment for pain. There's good evidence for this. And while the RCTs have not demonstrated benefit of excision over ablation, most experienced endometriosis surgeons believe that we should excise lesions where possible. And we should always do laparoscopy rather than laparotomy for obvious reasons with respect to patient recovery. It's also important to note that if we can do cystectomy for ovarian endometriomas, we should, but it's absolutely certain that we should not do a great deal of damage to the ovary to perform a cystectomy. If a cystectomy becomes too difficult, it's better to just ablate the remaining tissue, potentially even leave a little bit of endometriosis in the ovary rather than destroy the ovary and all the eggs that are there. Now, once the surgery is done, it's important to document what we found. The 1985 revised AFS classification endometriosis has been the most commonly used system, and it does help with determining the amount of disease that's there. The problem, of course, is it does not have a correlation with pelvic pain, and it does not have a correlation with pregnancy rates afterward. The endometriosis fertility index, which we published in 2010, will predict will predict pregnancy rates after laparoscopy. So if you have a patient with endometriosis at surgery who wants to get pregnant, the endometriosis fertility index, or EFI, should be used to help predict what the pregnancy rates are going to be afterwards. There's a free app online at endometriosisefi.com that you can fill out, and it would automatically calculate the scores, give you life table curves, and help you counsel your patients about what to do. The EFI is a simple, robust, and validated clinical tool. It predicts pregnancy rates following surgical staging of endometriosis and can be very useful in developing treatment plans. The EFI has now been validated in 22 additional studies in about a dozen countries around the world. So this is an index that works and can be used in the infertile. Now, a question that commonly comes up, well, we know what surgery does and we know what ovarian suppression does, but what happens if you use them together? And what the data tell us is that if ovarian suppression is used prior to surgery, there are no data that show any benefits after the surgery. And if the ovarian suppression is used post-operatively, there's no data either that show a benefit. And therefore, it's not necessary to use ovarian suppression before or after endometriosis surgery to get better results, because it doesn't work. And so the same recommendation not to use it in the infertile patient stands. However, it is true that it is likely, although not absolutely proven, but likely, that ovarian suppression of severe disease before in vitro fertilization may improve pregnancy rates. And so it's reasonable to use ovarian suppression for 2 to 3 months prior to IVF. And so what are the indications for IVF? Well, it's the best treatment for tubal disease and adhesions, for a refractory or severe endometriosis, or if surgery's not been successful, for male factor, for age-related infertility, unexplained infertility, failure of other treatments, and difficult to control PCOS patients. It does not solve severe egg problems and severe uterus problems. In those cases, third-party reproduction with egg donor or gestational carrier may be necessary. So in summary, summarizing our endometriosis management, when there's pain, initially the patient should have analgesics, NSAIDs, and OCs, and as a second line, progestogens, GnRH agonists, or antagonists. If there's infertility with other factors being fairly normal, it's appropriate to start with clomiphene, 100 milligrams cycle day 3 to 7, and IUI. 3 cycles is reasonable. In the very young patient with short duration of infertility, it may be appropriate in some patients to go up to 6 cycles, but not more than 6 cycles. Other ovarian stimulation regimens can be used, but care should be taken to avoid multiple pregnancy. If there is persistence of pain and or infertility without other infertility factors and favorable patient, then a diagnostic laparoscopy carried out, but should be performed so that operative laparoscopy to treat the disease can be carried out. In addition to that, we should all be thinking about complementary medicine, physiotherapy, alternative medicine, and mind-body work with our patients, especially those who are moving towards a 6-month mark where they're getting into chronic pelvic pain, and definitely for all women who have chronic pelvic pain and endometriosis. Some of the factors that are important to know in making our decisions is that surgery well performed is effective treatment for infertility and pain for all stages of endometriosis and endometriomas, and pre-IVF possibly for large endometriomas, say 4 to 5 centimeters or more, not for small endometriomas. Important to note that repeat surgery is of some benefit for pain in some patients, but it has very, very limited benefit for infertility. Ovarian suppression should not be used for infertility by and of itself. It can be effective for helping with pain, and all the medications are equivalent statistically, but some patients clearly do better with some than others. And it may be that ovarian suppression is beneficial with severe disease prior to IVF when used for 2 to 3 months. It's also important to note that there's no effect of endometriosis on IVF live birth rates, except with large endometriomas and or extensive disease, which may alter the pelvis sufficiently that there's a reduced number of eggs that are retrieved at IVF. Now, moving on to look at our final comments regarding endometriosis and trying to address these dilemmas. The World Endometriosis Research Foundation was founded about 15 years ago to start to address this, and started out with a number of papers as our early projects, multi-center studies of the global impact of endometriosis and associated symptoms, looking at the cost of illness, the cost of endometriosis, looking at the impact of endometriosis on the quality of life and work productivity, and looking at the burden of endometriosis, the cost and quality of life. And these were important studies that started to raise questions and get information about endometriosis, as well as learning how to develop symptom-based predictive models and clinical screening tools. And so these are important foundational studies that the World Endometriosis Research Foundation did. Subsequently, became involved with the World Endometriosis Society to try to develop consensus on endometriosis around management and also around classification. In addition, WERF and WES have worked on research priorities starting way back around 2008 with recommendations for research, followed up in 2011 Montpellier Conference, more future directions, and then later we've had other consortium in 2017. And what's been identified is these are the major areas in which we need to do research to address these dilemmas: pathogenesis and pathophysiology, symptoms, diagnosis, classification, and prognosis for different kinds of patients, for pain, for infertility, for endometrioma, for older patients, younger patients, different stages. And we need to know how to manage the disease and symptom management, and we need better research policies. By 2014, we had 109 recommendations, and in 2017, we updated this chart on research priorities in endometriosis. We also published a paper with respect to ovarian endometriomas and IVF. We're still not entirely clear about how endometriosis should be treated before IVF. There's no definitive information, and so a large RCT is needed. There is a study that's being started in Northern Europe on this. A very important publication from 2014 was the effect tools, the World Endometriosis Research Foundation Endometriosis Phenome and Biobanking Harmonization Project. These 4 papers address standardization of history collection and also specimen collection. So surgical history and findings, clinical history and findings, fluid collection and storage, and tissue collection and storage. And as a result of starting the effect study, currently we have 47 centers in 21 countries around the world that are collecting data and specimens in a standardized fashion, and now are beginning to collaborate to share these standardized databases and with new information to perform research in endometriosis. And finally, I'd just like to address the World Health Organization recent fact sheet on endometriosis. This fact sheet was a very important development. It was just published March 21st of 2021. And it was a great step forward for the endometriosis community globally. The WHO identified current challenges in endometriosis. They said we need to increase awareness of the general public and frontline women's healthcare providers so that we can also help to mitigate the normalization and stigmatization of symptoms. The basic story here is that for many women, especially younger ones, their pelvic pain and their problems with menstruation have been normalized as being that's what happens to women, even when it's not true and they're having a significant life issues, quality of life issues with their symptoms. In addition, because this is about sexual and reproductive health, many are stigmatized by these symptoms. So it's very important to start to change societal perspectives on this. In addition, by increasing awareness, we have to reduce diagnostic delays so that we can initiate treatment earlier with the NSAIDs, OCs, and progestins as noted. We also have to identify better systems to get earlier and increased access to secondary and tertiary expert care. especially specialized surgical care, which is difficult to find in many, many parts of the world. And of course, we need to develop multidisciplinary teams. And this is true everywhere in the world, including in developed countries. There's an urgent need for non-invasive diagnostic tools and biomarkers. These are not yet available. A lot of research is going on, and we certainly hope that one or more of these will soon be validated. We also need to have better understanding and use of medical treatments that can manage pain, but still enable pregnancy to occur. There is one medication out there now that could potentially fit that role. We need to look at the priorities in endometriosis. The WHO states that these are to increase awareness of healthcare workers and all of society, but in particular, men, adolescents, and teachers to help get to endometriosis patients earlier. Training the healthcare providers includes improving their skills in diagnosis and management, but also having them know when to refer patients. We need to train surgeons for advanced disease and develop multidisciplinary teams. We need to also ensure that primary healthcare, primary women's healthcare, plays a role in basic diagnosis and treatment. Otherwise, tens of millions of women are not going to get their disease diagnosed early enough. And we have to advocate for health policies that give access to this primary care, i.e. universal healthcare on a global basis. But once women get to the primary care, if they have diagnosed endometriosis that can't be managed there need to be set up efficient secondary and tertiary referral systems. The WHO that believes that the other priorities include strengthening the capacity of health systems to achieve this early diagnosis and treatment. And we need to increase research. And again, their list looks very similar to that from Wirth and West: pathogenesis, pathophysiology, and what's the natural course of disease, genetic and environmental factors, prognosis and disease classification. Very important to know how to look at prognosis for different approaches, whether it's pain or infertility or both. To look at non-invasive diagnostic markers, personalized treatment paradigms, the role of surgery, when should we do surgery or not, novel targeted therapeutics in the medication world, which are a very big topic now with a lot of progress. And we need to look at preventive interventions, which hopefully could slow up or prevent the disease. To achieve these goals, we're going to need collaborative global action and also, of course, to increase access with universal care, especially in lower middle income countries. And finally, when we're looking at health, social, and economic benefits of addressing endometriosis, they are huge. With a couple of 100 million women affected, there are significant social, public health, and economic implications of endometriosis. This disease decreases the quality of life with pain, fatigue, depression, anxiety, and infertility. It limits or prevents women and girls going to school and or to work, and disparately interferes with sexual life and reproduction. By addressing these conditions, we will empower girls and women and support their human rights. So today, with respect to endometriosis, we have no known prevention methodology. There's no known cure. There's no way to prevent. And the focus needs to be on enhanced awareness so it's diagnosed earlier, and so treatment, as we've outlined today, can be initiated. This treatment may slow or halt progression. It may reduce the long-term burden of symptoms and reduce central nervous system sensitization and chronic pain sequelae. So thank you very much for being here today to listen to this lecture. I'd be very happy to take any questions.
Yeah, thank you very much for your wonderful talk, Professor Adams, David, and you gave a lot of importance to diagnosis and the management. And with the permission of Dr. Jaideep Malhotra and Narendra Malhotra, I would ask some questions. Maybe I think Jaideep should start first, and then I would ask.
Sure, go ahead, Pratap. The floor is all yours.
You can start, and then I would continue. Yeah.
I think, David, this was a wonderful presentation. Exactly, the kind of guidance which we were really looking forward to. And I know. I think you could probably think about touching a little bit on adolescent and early endometriosis. How easy or how difficult it is, to diagnose and then treat it.
I think the most important point I'd like to make for the many physicians who are out there is to always think of endometriosis, being suspicious of it and aware of it, I think is most important. And there would be two major aspects of where increased awareness can be helpful. The first is that endometriosis can occur in young women. It can occur in women that are 15 or 16, even younger sometimes. And so when a young woman presents to their healthcare provider with a complaint of pelvic pain, it's very important to listen to them and to take them seriously, and to consider endometriosis as a possible cause of their problems. The second point is that it's relatively easy to do something that is very often effective, and that is to use a simple non-steroidal drug or a progestin or oral contraceptive medication in the woman who's first presenting with these symptoms. And I think if we could get all the primary care doctors and even women's health doctors who are more specialized, like our obstetricians and gynecologists on the phone, to listen to the woman and then try something simple. Many, many millions of women who currently don't get appropriate care would be helped if we could just start with that approach to the women who are coming to see us. It's not normal to have so much pain with periods that women cannot go to school or cannot go to work or cannot exercise. This is not normal. We should help these women, and we do have the tools to do that.
Yeah, thank you so much for your answer. And Jaideep, can I continue the questions? Yeah. Professor David Adamson, and you clearly mentioned about not to do laparoscopy for just for diagnosis, and you said only for surgical management. And you also said that IUI will be just about 5% or so, and we should not be doing IUI for even endometriosis. And you also mentioned about not to do unnecessary surgery. That's what we all appreciate. But sometimes I feel that people are asking for CA 125. Do you think it is significant about that?
I'm sorry. Sometimes people are
asking for investigation like CA 125.
Yes. The CA 125 has been studied quite extensively, and there is some correlation with amount of disease and CA 125. But unfortunately, it's not reliable enough to be able to really predict a treatment on it. And, based on the number result that we get, I really believe that with endometriosis, the important thing is to listen to the patient and treat the symptoms, treat the quality of life issues for the patient. Is this about pain? Is it about the bowel or the bladder or with intercourse? Or is it about infertility? But I do not think we should be treating the number. So I would say that you can do a CA 125 test, but it is not going to be that helpful because it just in a very rough way can predict amount of disease. And secondly, we don't want to be treating a number. The number itself is irrelevant to the woman, absolutely irrelevant. So we should treat the symptom to improve the quality of life. And that's why I don't do CA 125s, because it doesn't help me do what's needed by the patient. And I think that's where our focus should be.
Thank you so much for your answer. And because a lot of people in what I've met, some people they think that high CA 125 may be malignancy. I always tell them it's not malignancy because endometriosis can have an increased CA 125. And I've seen patients where they've removed the ovaries, which is really bad. They can done cystectomy for that. My next question to you is that what do you think that the theory of neonatal bleeding can be the cause of endometriosis?
it's very difficult to know the exact relationship between menstrual bleeding, retrograde menstruation, and the volume of blood. There are certainly studies that suggest to us that if a woman is having very heavy bleeding, heavier bleeding, that there's a correlation with endometriosis. And certainly another very common and important problem for women is heavy menstrual bleeding, abnormal uterine bleeding. And so I think when a woman presents with this problem, the focus should be on solving the bleeding problem. The bleeding problem may or may not, in that particular woman, have a significant role in endometriosis. But the bleeding is a problem by itself. And so I would address that problem and try to assess whether it's obviously endocrinologic or whether it's a polyp or a fibroid. Of course, it could be adenomyosis or whatever the factor might be, but to try to deal with the bleeding problem by and of itself, knowing that it may or may not have a significant role with respect to the endometriosis, but it is important to treat it on its own merits for the woman.
Thank you.
Yeah, I think
Pratap was on neonatology.
Yeah, Pratap.
Neonate bleeding, a newborn bleeding. That was my question. A newborn, the girl baby bleeds after birth. So do you think it's significant?
I'm sorry, I don't understand the question.
David, he is asking, is there a relationship between early neonatal bleeding in a girl child and her developing endometriosis later in life?
There is some relation, and that's why it's an important symptom or sign when she says she's bleeding, that's important to note. And yes, it might have some correlation with more development of more endometriosis or the increased risk of endometriosis. Heavy bleeding is a factor, but I'm also saying that by and of itself, heavy bleeding should be managed. So it's not just it should be managed because it's got a correlation with endometriosis. It should be managed because it's a problem for the woman. We want to manage the symptoms. And so it's important for both reasons. It's important for both reasons.
Yeah, correct. Thank you. Naren, you can ask some questions.
So what about deep infiltrating endometriosis?
Deep endometriosis is a very significant issue on both sides of the spectrum, because some women have deep endometriosis and have very few symptoms. Other women have deep endometriosis and have life-altering symptoms, with bowel problems and bladder problems, and also with pelvic pain. I think if the woman has deep endometriosis and she's having a lot of symptoms, then there's no question that surgery can be very, very helpful. But as we all know, this kind of surgery is extremely difficult technically. It's very challenging surgery, and it should only be attempted by surgeons who really have the appropriate training and experience to manage that patient. And so it's very important for the gynecologist to refer that patient for the best possible care, because we also know that the very first operation is the most important one. If the first operation does not go well because the surgeon is not too well trained or because there's a complication, it's very, very difficult to recover from that down the road. So the first operation is very important. Now, the other side of the equation is some women have deep endometriosis, but unbelievably, they do not have a lot of symptoms. And so in those cases, it's important to do a good workup on the bowel and the ureters and the pelvis to see if the systems are compromised. If the ureter's been compromised and the kidney is being compromised, then it's essential to do surgery to help to resolve that situation. Same thing if there's a bowel lesion and significant bowel occlusion. It's very important to treat the patient. They may even be asymptomatic or have very few symptoms, but it's important to do a good workup and find out, with imaging studies and IVP, etc. Now, the challenge comes if another challenge comes if they have deep endometriosis, but they're not having many symptoms, and you do a workup And even though there's deep endometriosis, the bowel lumen looks very good. The kidneys look fine. The ureters don't look as though they're compromised, even though there might be a lot of disease in the pelvis. Then the challenge is, should we do major surgery that is very difficult surgery, has complication rates with it in a patient like that? And I would say most of the time the answer is no, we should not do surgery if the woman does not have symptoms. Again, we want to be treating the patient and her quality of life with the mind, with thinking about what's the future. And so a woman like that, I would almost certainly put on ovarian suppression on a continuous basis with one of the methods we've discussed to try to keep the disease in check so that she doesn't get symptoms, and hopefully the disease might not progress and she would be able to avoid very major surgery. So it's an excellent question, because deep endometriosis can be very, very challenging because of these different clinical scenarios for the patient.
Yeah, thank you so much, Dr. Narendra Malhotra. I will ask a supplement question to him. I found one of my patient coming like an appendicitis kind of a patient, severe pain on the right iliac fossa. And do you think deep endometriosis can be the peritoneal fluid going around all over and causing some kind of similar appendicitis kind of a pain? You have to unmute yourself, David.
Yes, thank you very much. Yes, I think the appendix certainly can be involved, and the bowel. And if when I'm doing surgery for endometriosis, if the appendix seems to be involved, I think it's very appropriate to do an appendectomy to remove it. And certainly the appendix can be a source of difficulty with endometriosis in it. And your important point is, when we see someone with appendicitis, we do need to think that possibly endometriosis could be involved, and we need to look for endometriosis there and elsewhere in the pelvis, and the bowel, of course, too.
Pradeep and Naren, your next question.
Yeah.
Please.
David, I just wanted to ask you one thing. Like, we know that the oocyte quality is compromised in endometriosis patients. So when would you like to take a call on using donor eggs in these patients?
Well, I think the data on the oocyte quality is very complicated. So I agree that when there is endometriosis in the ovaries, I think it has a broad effect, right? We can have ovarian cysts, we have inflammation, it almost certainly can interfere, with many aspects of the oocyte. When there's endometriosis that's not involving the ovary, or not really extensive endometriosis in the pelvis, it's far less clear how much impact that disease has on the egg quality. So I would not automatically think of egg donation with endometriosis. I would work on the evidence, meaning what results do we get with that patient. So if we do IVF and we get a reasonable number of eggs and we get appropriate fertilization and development, then I would continue with the patient's own eggs. If we did not get many eggs, if we did not have the appropriate development, and of course, woman's older, whatever, I would look at the whole picture. And then certainly egg donation may be appropriate in some patients, but I would not start with the a priori assumption that because of the endometriosis, I need to, go to egg donor sooner. I think it's an appropriate option, but only in the woman who demonstrates that she's not able to get a reasonable result with her own eggs. But it's why it's so important not to damage the ovary, especially in younger women, right? With endometriosis, very important to preserve the ovary.
I think it's a very important take-home message, because a lot of times, people just jump to egg donation, and I personally also feel it's not really ethically or morally right.
I agree.
Yeah. Naren, you want to ask a question, or before I can ask another one? Yeah. Okay, recently a lot of papers have come out with microRNA and future for the therapeutic effect of microRNA in endometriosis. What's your opinion about microRNA?
Well, I think it's a very exciting area of development. I had one paper there about a recent paper, one slide about how microRNAs are now being assessed. I think research in this area is very, very important. Again, I think it's important that the studies that come up with results be validated. One of the biggest issues about all of these different types of biomarkers and the pathophysiology, it's very important to look at which patient are we talking about. Are we talking about patient with infertility, or a patient with pain, or a patient with an endometrioma or deep disease? Are we talking about a younger patient or an older patient? And we need to define the patient population that is being studied, regardless of what the study is about, microRNAs or what have you. We need to define the population and prospectively have a very good study design to look at the results. Because we all know that if we look at enough different things, we're going to find some that are correlated just by random events. But that does not show cause and effect. So I think, to answer your question, this is one of the important roles we see of the effect studies, is that we're getting centers from all around the world so we can get very big data sets, so we can define different populations and still have a large number of people who have all had similar data and similar specimens to do the studies. This is one of the other issues about the studies, is if you have study done in India and a study done in Europe and a study done in Latin America, they can get 3 different results, but the methodology of the study is very different. And so we can say, well, that didn't matter because they're different, but they might be different because of the methodology of the research that was undergone. So this is why we think collaboration and really strong study design is so important to move things forward. But it's a very exciting area of work, and I'm hoping.
Thank you very much. Thank you very much for that microRNA. My thought for the next 10 years is that a small molecule like microRNA will make a big difference in the future. And I think they would be upregulating microRNAs and downregulating microRNAs drugs. And that's what the future tomorrow for endometriosis. And I would leave Narendra Malhotra to ask the next question.
So we sometimes, when we do a cesarean section and we bring out the uterus, we see a lot of bleb lesions on the posterior surface. Pregnancy endometriosis. It is said that pregnancy suppresses endometriosis, but a lot of people recently have asked me, what is this? We're seeing endometriosis flaring up in pregnancy. Is it the progesterone, the A receptors and the B receptors working there? I mean, what is happening there?
Well, I wish I really had the answer to that, and I don't. We certainly see it, and it's very odd. It's sort of counterintuitive, right? Not what we expect to see. And I think the only answer I can really give, it's still one of those big unknowns. And as Dr. Kumar has just pointed out, I think we're going to learn a lot about the microRNAs, about the biochemical pathways and the hormone receptors that we still don't really understand. We really don't understand it yet. And so this is why the basic research is so important, that we can understand the pathophysiology of this disease and try to figure out what is it that we're looking at there. It's a bit, like adenomyosis is a different condition, but it clearly looks as though they're related, but we still don't really understand the basic elemental disease process here. So hopefully we'll get a better understanding. So the answer is I don't know what it is.
Pratap, you're muted.
Yeah. There's another question from the audience here. You mentioned about central sensitivity syndrome. That means, do you think that somebody has endometriosis has Even a little bit of touch may cause like a severe pain.
Yes, again, this is a very complex area with central sensitization. There's just so little known about it, but there's no question that, first of all, every patient is different. And as we all know, there can be some women who have extensive endometriosis and have very little pain. I mean, it's absolutely surprising sometimes how much disease you can see with very little pain. And you'll find another woman who has very little endometriosis, and yet very, very severe and chronic pain. And there's clearly a difference in how those endometriosis lesions, but also the whole disease of endometriosis, is affecting their neurologic system. And we just don't really understand why that happens, but we do know that it does happen. I think this is one of the important reasons I have a message, which is we want to try to listen to our patients, and when they have pain, we want to try to start some intervention early, and not only with the medications that we've talked about, but also with emotional support and mind body, so that we can avoid getting into the situation where we know that once the pain's been there over about 6 months or so, the neurologic system in some patients will start to become very sensitized, and it becomes very, very difficult to pull that patient back from the chronic pain, which is why it's so important to try to start early interventions with the simpler medications usually, and then with more second line ones if necessary, and all the while giving emotional support, education, and working on complementary medicine with mind, body, and physiotherapy. Very important to try to avoid the chronic pain syndrome, because as you say, we've all seen patients and you just scratch your head at how they can have so much pain with so little endometriosis. There's clearly things going on we just don't understand yet.
Exactly. I think people who have very minimum endometriosis can have severe pain, and other vice versa. And I think central sensory syndrome tells us that even minimum pain can be kind of exaggerated in these kind of women. You have another interesting question that I think is a practical question by the audience. What's the size of endometriotic cyst you would not operate? Do not operate.
Yeah. So the size of cyst not to operate is a difficult question, but just a rule of thumb. I think these days, if it's less than 4 centimeters, I'm very inclined not to operate. General gynecologic principles for decades have been that if it's about 5 centimeters, you probably should do surgery to make sure that you don't have a malignancy. Of course, you do not usually have a malignancy, but the risk is going up. And I think somewhere between 4 to 5 centimeters, it's a more difficult clinical question. And it depends on the woman's age. It depends on her symptoms. It depends on whether she's trying to get pregnant or not, whether she has access to IVF or not, and how much pain she has. So I think I'd say maybe in the 3.5 to 5.5 centimeter range. It's a detailed conversation with the patient based on her clinical situation, with increasing probability of surgery as it gets bigger in that range.
Yeah, thank you. Naren, your next question.
So is there, when we talk of pregnancy, also someone is saying that they're seeing that endometriosis treated patients land up into preterm labors. So how does that correlate? Is it to the disease or the inflammation?
So I'm not sure of the answer to that, except when we look at reproduction overall. When we look at reproduction overall, we know that infertile patients do not reproduce as well as fertile patients. So if a woman can get pregnant consistently within 2 or 3, 4 months, she has a very effective and good reproductive system. And that woman will, generally speaking, have a fewer complications in pregnancy, less preterm labor, and better obstetrical outcomes than a woman who, say, takes 12 to 18 months to get pregnant, or a woman who has infertility. Duration of infertility matters so much because I think it's a marker, if you will, for how robust the reproductive system is. And so if a woman has endometriosis, that's a reproductive system disease or problem, and it may or may not cause infertility. But if you have reproductive system diseases, you're in a population of women who generally will not reproduce quite as well. So I think there probably is a relationship between the two. We don't know exactly what it is, but basically on average, that woman's reproductive system will not function throughout the pregnancy, and the outcomes will not be quite as good. And so that's why we see these problems more often. One of the difficulties is it's difficult to predict which woman is this woman going to have that problem. I mean, that's not really easy to do most of the time. But generally speaking, more reproductive system problems, getting pregnant, endometriosis, fibroids, more reproductive outcome complications and problems on the other side.
Yeah, thank you very much. I have another interesting question for you. What's the role of intracrinology in endometriosis? Because we always aromatase inhibitor may be the problem. So what's the role of letrozole in endometriosis?
Well, I've not used letrozole specifically to treat endometriosis. Of course, we use it for ovarian stimulation, but I've not used it as a primary type of management. I generally, obviously in PCOS patients, but with the, I would start with clomiphene in most people. And then if we don't get the response we want, move to letrozole. A lot of people like letrozole a lot, and I think it's perfectly fine if that's what someone is comfortable with.
Yeah, thank you. Because the suppress endometriosis for letrozole, but not the role of dynogest in dynogest for a person who's not trying for pregnancy.
Okay. Yeah, I haven't used that in that way. Usually I will go to oral contraceptives first because they're cheap and freely and easily available, and we know what the profile looks like on them. Progestins mostly do have issues over time with depression and irregular bleeding. So it's not that I don't use them, but I don't usually go to them first. And I've not used letrozole clinically as a first line management of the patients. And then I go to GnRH agonists with ADVAC, which has been very successful strategy, and sometimes leave people on that for 2 and 3 years, as long as we're obviously checking their bone density and everything is going well. I think just to sort of add to the thoughts here, it's very important when a woman comes in with endometriosis and it's diagnosed to talk with her about this disease and how it can impact her fertility potentially and pelvic pain, and to develop a reproductive plan with her, because I think it's important not to be all over the place with different kinds of drugs all the time. You want to talk to the patient, try to get a plan. We're going to use birth control pills for 2 or 3 years. You should be trying to have your family sooner if you have endometriosis. And so when are you going to start having your family or not? And to work, you can't be exactly precise about everything, but to get a reproductive life plan for the woman with endometriosis, so she knows if she has extensive disease at 30 that she might be facing a hysterectomy at 35 or 36, and you want to discuss that and plan. And part of that planning is what kinds of medications are available, what kind of options do we have, and when are we going to start using them? Of course, you change the plan as time goes by and as different things happen with the patient. But I think it's important to have a plan. I don't think it's a good idea to just pull things off the shelf and look for treatments. I think that's a bad approach because the patients lose confidence. And I think it's very important to follow the evidence. If there's not good data, this is just my approach. If they're not good studies saying that this is safe and effective, then I don't think we should be using them until we get to very, very complicated situations with patients. And that's my approach, is try to be organized, standardized, evidence-based, plan ahead, and then make changes as you need as the patient responds or doesn't respond to your interventions.
Thank you so much. There's one last question by the audience. What's the role of doing MRI for extensive endometriosis diagnosis?
Well, MRI is a great question. MRI, of course, is a very good technology, and it's definitely much superior to CT scan. I would only do a CT scan if we could not do an MRI. So use MRI. It's not needed for everybody, but MRI can be very, very helpful in assessing the extent of disease, obviously in the bowel, in the ureters, in the bladder, and certainly can assess the uterus with respect to the size of the uterus, myomas, adenomyomas, adenomyosis, deep cul-de-sac disease. So if I were considering trying to make a decision to do surgery or not do surgery, then I would do an MRI, and it will be helpful to make that decision. And it will also be helpful in planning surgery if it's going to be done, to know if you need a urologist there to deal with the ureter, or a general surgeon to do a bowel resection, or whatever the plan's going to be. So I think in a woman who has extensive endometriosis, or in which there's concern about how much, we're not really sure how much disease she has, an MRI is very, very helpful to assess the extent of disease and to plan, make a decision about surgery, and then to plan the surgery if it's going to be done.
Thank you very much, Naren and Jaideep. The last question by you all.
Yeah.
Thank you. No, I don't think we have any other questions. Thank you very much, Davidson, for fantastically explaining the whole process of diagnosis and management, and of course, clarifying a lot of these questions, the doubts which are there. Jaideep, to conclude.
Yeah, thank you, David. Thank you. That was really awesome. I am full of questions, but I know that we have time limitations and it's also early morning. You have to also go to work. Thank you so much for sparing all this time and effort and deliberating a wonderful, wonderful talk. Thank you so much.
Thank you very much.
Pleasure. Thank you so much. Have a nice evening. Bye now.
Thank you. Yeah, Shubhajit.
Thank you. Thank you, Dr. David, for a wonderful session. And I, Shubhajit, on behalf of Acumentis Harmonica, thank you very much. And I also thank Dr. Yvonne for being the course coordinator. And thanks to Dr. Jaideep Malhotra, Madam, for her guidance, help in bringing FIGO RAI certification program on endometriosis for our Indian doctors. I must tell you, Madam, that this is the program where we have crossed 1,600 attendance, by far the best, absolutely. And I really thank you all and my sales and marketing team who have worked to get this done, basically. And of course, last but not the least, we would like to acknowledge DocMod Health for being the technical support partner. We look forward for each one of all the doctors who are attending to participate in the next module of this FIGO RIA Masterclass in September. Thank you very much. Good night and namaskar. Thank you.
Thank you.
Bye-bye.
Thank you so much.